सीधा था. Okay.
This is my talk on phakic lenses, expanding indications. So, how many of you all are doing phakic IOLs? Okay, many more than Smile, so that's good. I am a consultant to Carl Zeiss, Meditech, Biotech, and also Star. So we all know that the indications for phakic IOLs, you can treat if it's ICL, if it's the EVO with the central hole, you can treat from minus 0.5 to minus 18, correction of myopia. And if it is a toric, minus 0.5 to minus 18 with up to 6 diopters of SIL in 0.5 steps. And with the other Indian phakic IOLs, you can treat up till 21 diopters. For the hyperopic ICL, you can treat from 0.5 to 10 diopters of sphere and up till 6 diopters of SIL. And but you need peripheral iridotomies. For the hyperopic ICL, you don't have the center flow. So let us look at the expanded indications. So we all know that we can treat myopia, myopic astigmatism, and hyperopia, and it is very suitable for high range of refractive errors. But some of the expanded indications are, one is bioptics, which is a combination of a phakic IOL with LASIK, SMILE or PRK for very high myopia. And this was first described by Roberto Zaldivar. Then you can also treat keratoconus, though keratoconus the company says is a contraindication, but we have been treating keratoconus, stable keratoconus with the best corrected vision of better than 6/12. These patients do well. And you can also combine it either after C3R, intrastromal rings or topo-guided PRK. And then when you have the residual power, you can correct it with the phakic IOL. You can also use it to correct high astigmatism following penetrating keratoplasty or DALC, and these are cases where you get residual refractive error, and sometimes you can get a surprise and a high cylinder, and though you have done an excellent job, the patient is not happy because of the refractive error. You can also correct presbyopia, and these are the newer lenses which are available. You can of course do a monovision phakic IOL, and that is what I do and prefer for most presbyopic patients. But you also have presbyopic phakic IOLs. You have the one from AIOC, which is basically a diffractive lens, and then you have the EDOF lens from Star, which they call the Vivo. That is the Vivo ICL. And the other indication is pediatric phakic IOL for correction of high anisometropia and amblyopia reversal, and this works very well. I have done about 12 cases of pediatric phakic IOL, and they do very well. You can also use the phakic IOL as a piggyback lens to correct any residual pseudophakic error. So this is a case of bioptics with SMILE. So first we are putting in the lens to correct the myopia, and you can correct myopia of up till 19 diopters with the ICL. So you correct whatever is maximum is possible, and then after 3 weeks you can dock and then do a SMILE treatment to correct the residual myopia and astigmatism. And we did a series, and then that is the lenticule extraction. This is my technique of lenticuloschisis, where it's a no dissection technique. You just hold the lenticule and grasp it, and then you can just, like a rhexis, you just pull it and then you can extract it. And this technique also has been published in the GRS. Of course, you need to optimize your energy. And we published the results of the bioptics in GRS. This is for keratoconus, where we are treating after implantation of Keraring and C3R. You wait for about 3 months, 3 to 6 months, and then the residual power is being corrected. You can see here I am using a toric ICL. And you can regularize the cornea with the intrastromal rings, stabilize it with C3R, and usually the best corrected vision is better than 6/12. If the vision is less, best corrected vision is less than 6/12, then the patient satisfaction is not good. So that's why you correct any irregularities, you regularize the cone and then do the ICL. This is a post-DALC ICL. You can see the DALC here, and then this patient had astigmatism, high astigmatism, so we are using a toric ICL, and then I'm using the Callisto on the Lumera 800, the RTO, and placing the, you can see the Z align there. It has to be placed at 163 degrees. So this is a markerless system which we use both for toric IOL and the phakic toric, and you can see the optical zone here, and of course this is the rescan. So you can see the, I just wanted to show the incision and also the DALC here. This was a pediatric ICL, a 9-year-old boy having high myopic astigmatism, anisometropia in the right eye with amblyopia, and we did a toric ICL in 2008. His refraction was -13 with 3 sil. Spectacle best corrected vision was 6/36, and we implanted a -22.5 diopter plus 5.5, and under intravenous general anesthesia, and did a peripheral iridectomy. This was before the center flow. Post-op vision improved to 6/9 after amblyopia therapy after 6 months. So we find that the amblyopia reversal is excellent in these cases of very high myopia with anisometropia. So this was the pediatric ICL. We usually give intravenous anesthetic because it's a very short procedure, so you don't have to intubate also. So it just takes like a couple of minutes. And you can see this was 2008. That's when you used to get higher power ICLs. We didn't have the markerless system, so positioning it with the Mendes marker, and I usually put one suture so that the wound is safer. So those were a few of the extended indications for the ICL. Thank you very much. If there are any questions, I can take them, and Pooja is setting up her talk.
Thank you, Shri. Yeah, Ritu.
Can I ask, how's your experience with the presbyopic phakic IOLs?
See, basically, I don't like the diffractive ones because you have a lot of night vision issues, and these patients want good vision. So I prefer to do a monovision, and the monovision, if you just do one diopter, it is good enough, because most of these phakic IOLs have image magnification, and 60% of them have improvement in the best corrected vision. So if you just have one diopter of anisometropia, the non-dominant eye, make it myopic by one diopter, these patients are extremely happy. And what I've seen is, I've been implanting ICLs from 2002, and many of these patients have become presbyopic now. They are in the presbyopic age, but they don't require reading glasses, probably because of the image magnification, and some of them have a slight progression of the myopia, the very high myopes. So they have like about 0.5, 0.75, and they are comfortable both for distance and reading, and usually don't wear glasses. But if you have a presbyopic patient who is a high myope, then the monovision works very well. They are able to tolerate it. The one from Star is basically a need-off lens.
Need-off.
It doesn't have the rings, but again there is limited experience. I don't know India whether it is available as yet, but
no,
it should be.
I think it will take another 6 to 8 months.
The Viva should be introduced shortly.
So any experience in pseudophakic patients where you've got a monofocal lens and you've put a...
Yeah.
I have done that.
Pseudophakic patients, I use it to correct refractive, residual refractive errors, either a cylinder or a sphere. But
so for a patient who is wanting
multifocality, again you can do a monovision, but I don't know how well maybe the diffractive lenses from AIOC may work, but I have no experience.
Thank you.
I was talking about high ametropia for a pseudophakic patient whom I operated 20 years ago as a congenital cataract. So that patient had a -17, -18 refractive error. So I used an ICL because Rayner circumflex you don't get in those powers. So I used an ICL to correct the ametropia. There was a lot of fibrosis of the capsule and things like that. So I couldn't do an explant. Either I went in for a glued IOL or I put this as a piggyback. So I have used the ICL as a piggyback, but I'm not talking about the multifocal or anything like that. I think the EDOF lens by Star is going to take about 6 to 8 months more. They've applied because all of them come under medical devices and each one of them has to be certified by the DGCA. So that's why it's taking a little
They
while.
launched it in the last ESCRS. It's called the Viva.
Viva, yeah. No, there was a big noise even in US at the Ascaris. There was a big noise about it. Yeah, go ahead.
See, basically, yeah, this is for patients who have a clear lens.
Yeah.
And if you have the center flow, then the incidence of cataract is quite low. Cataract, which happens in ICL, is more of an anterior subcapsular rather than nuclear sclerosis. But once you open the eye, then there is definitely a higher incidence of nuclear sclerosis.
No, what he is
many
saying
of these
is
patients,
he is talking that basically they are above 40. So would you prefer a prelex? So the
No,
only thing is that if you are looking at a very high myope, the RD incidence, etc., could be this thing. So
that and of course, if you have a diffractive lens, then night vision issues can be there.
So EDOF doesn't give that kind of reading ability. It's the same like you have, like what you have today, a Vivity, or you had the Symphony. So basically they are there, but they are. I personally don't do a lot of EDOF. I feel EyeHands gives you as good intermediate kind of a vision with a slight mono vision you can actually get. So EDOF is, I don't know.
But these are early. See, these are early presbyopes, 40 to 50 years, early presbyopes with high myopia. So even that little bit of, one diopter of depth of field which they get is good enough for them to kind of manage without the reading glasses. So that is the principle on which it's kind of, but whereas if you do a refractive lens exchange, then you have other risks, detachment, CME, PCO, all these issues that come in. Plus they have the diffractive rings, which the night vision is not so good. So it might be, but I personally prefer to do a monovision, one diopter of monovision. These patients are extremely happy.
Thank you very much, Dr. Shri Ganesh. I think we still have,